Our previous topic of adjustment disorder, grief and loss, and today's topic is suicide. There's a chapter in your book. I will tell you some of the statistics in there are out of date, and what you have on the board is the most current material. And I will tell you, yay, this will not take until 12 o'clock, okay? Some students have a meeting to go to, and so that's fine. And yes, there's a quiz, and it's going to be a fun quiz. And everybody can make a good grade. And if you're not here, you are not going to be penalized. So that's my thoughts on that. So,
on Ira?
You got it? Okay, so with this topic, as you know, I always try to have some type of impact other than just, let's look at the material. So, because it is a difficult topic for a lot of students, and I decided I would tell you about my experiences with suicide. Okay? My brother's wife committed suicide. And yes, she had a lot of problems. But I will tell you guys, the one thing that I learned from that experience is how hard it was for him, and it's taken him years, okay, to move on. Why? I learned how hard it was for him to grieve. You remember how last week we did our little exercise and we looked at that grieving process, right? And there's no clear-cut stages to grief. Not everybody goes in a certain order, but when you're there and they're dead, there's not a whole lot of denial. There's not a whole lot of bargaining that I saw in him. All I saw was the guilt, the raging guilt of, why didn't I come home earlier? Why didn't I lock the meds up? Why didn't I do this? Why? And it has been very, very difficult for him to move on because of that guilt. And not just him, his son. When things like that happen, I saw that intense guilt and blame that he took on himself as to, why didn't I pick up on this? And those are things that can be very, very difficult. And like I said, I'm trying to tie it back to what we did last week as far as the grieving process. Another incident that has happened to me that I hope will never, ever happen again. And I have actually complicated grieving about this, which means it's unresolved. It's unresolved grieving, okay? Why? I won't tell you his last name, but I keep this in my bag. I cannot throw it away. This is my second year. He was my second year nursing student. He injected himself with insulin in his vein. And why am I showing this? It's very real to me. And I still am angry. Why am I so angry? He had the resources. Why do I feel guilty? I didn't pick up on it. Right? I didn't pick up on it. And I still have anger today. about this, okay? And I can't get rid of this. I have on my computer a PowerPoint presentation his group did. It has his voice. Why can't I get rid of that? Because I can't come to terms that he did this. I can't still understand the whys. Okay? If this topic, and I truly mean this, guys, is too sensitive for you, because I've been doing this a long time, please feel free to leave. There are a lot of things we talk about in nursing that is very, very difficult for students. Okay? So, please know that. So, I have complicated breathing. Hint, hint, hint. I'm also trying to point out things you may see on a test. Okay? To let you know what is really in the books and theory is this is a huge problem in this country, okay? Why? It is now the 10th leading cause of death in the United States. That has gone up from what was not long ago the 11th leading cause of death in the United States. It's now the 10th. Get this, guys, this has gone up. Second leading cause of death, 15 to 24 years of age. Now that's frightening. Do you agree? This is a lot of my students right here. Okay? Right there. And so as nurses, what I try to teach you is how to pick up on things, okay? And not take things for granted. Because you and I both know there are a lot of nurses out there, yes, they have RN beside their name, and they take things for granted, right? In what their patients tell them. And I don't want you to be that nurse, okay? You do not have to be in a psychiatric area to encounter suicidal patients. How many of you are in the emergency department? It is overflowing. We cannot get enough suicide beds now. I took students to the emergency department forever, and I watched the numbers rise when the economy went down the tubes. Right? You can't work. You can't have money. And this is what happens. For the majority of people, coping methods is what keeps us going. Right? We all have different coping methods. Okay? But at this time, they're not working. And that results in what is referred to theoretically a crisis. They are in a crisis situation and cannot find the coping methods to keep living. Okay? So this, in essence, is what happens with each individual. And we all know we all have different coping methods. So you may say to yourself, well, that's still, how does that help me as a nurse? Because that's so subjective, right? How do I help identify these people? Well, this is a great little tool. You will actually see variations of this tool, but the bottom line is what I have on this board. This is what I want you to not take for granted. Because statistically, these are the people that have a greater chance. Now, this is actually a scale, guys, and you can look in your book, like it gives points. Like this is 1 point, This may be 2 points. This is a biggie. If you encounter a patient who has had a previous attempt at taking their life, they are very, very high risk. So each of these has like 1 or 2 points. Now, if you're in the 6 to 8 point category, you need to seek psychologists, psychiatrists. Okay, that person needs help. And as nurses, what have you been taught? It is up to us to advocate. Dr. Smith, I think Miss Jones or Mr. Jones needs a psych consult. It is up to you to advocate for that patient. Okay? Even don't take signs and symptoms for granted. Okay? Because you have been taught what to look for. Okay? Now, again, males, why is that? If you remember, I said males are the ones that are more apt to commit suicide. Females are more apt to have suicidal ideation or attempt suicide. There are more people that attempt suicide that we know than actually commit suicide. Okay? And I thought this was interesting. It is usually by a lethal weapon, guns. So, age, why? Why do you think less than 15 and greater than 45? Hormonal. So coping methods get ineffective. Oh yeah, all of you been there, right? Right? You were 16 once. You were 15 once. Were you a good little girl? Were you a good little boy who never had problems? Yeah. So, why greater than 45? Okay, chronic illnesses, loss. So some of those coping methods are now being challenged, right? Because of these other issues that come into play in life. Now see, I know there's probably some of you sitting there, you can't imagine being 60, can you? Can you imagine being 60? I mean, what do you think your life is going to be at age 60? Some of you are like, I don't know, I don't care, I'm just trying to get through this day and get out of here. I mean, you know, that is a coping method that you may have. Okay? Some of you, I see some of your coping methods are your little digital little things that you gotta have. And see, I'm like, I get it. My daughter, I don't think she goes to the bathroom without that dang phone. She sleeps with it. Because I know if I see her phone and she's not around, something is wrong. Really wrong. Some of you, I see you with your little Red Bulls and your coffee and your snacks that are unhealthy and your Coke and your little sun drop. You all have different ways of coping, and that's fine. That's how we cope, okay? So, age. Remember, this goes back to adjustment disorder. What are the most common signs and symptoms? What's the most common signs and symptoms for adjustment disorder? Depression.
Anxiety.
Not anxiety. Depression. Hopelessness. Powerlessness. Tearful. Crying.
Rage.
Okay, those are more. So, depressed signs and symptoms are the most common, right? If you think back when we talked about major depressive disorders, depression is a huge diagnosis in this country, okay? So, depressed. This is a biggie. Previous attempts. And I know a lot of you think, how do you go about asking? Well, it's your responsibility to assess. And that's all I'm going to say. There are a lot of things we do in nursing we don't want to do. But it is your responsibility to assess and get the data because you are at the bedside. And oftentimes it is you that gets the little physician's attention to say, get in here. Something is wrong. Not the physician having all the answers and da-da-da-da-da-da-da. No, it's you that is responsible for getting that data and reporting what you actually assess. Physician ignores you, document it. Document it. That's what CYAs you, remember, those of you who've had me in clinical, document it. You think the patient's getting worse, pick up your phone and call again. They hang up on you, document it. Document it. You are trying to advocate for this person, and that is your responsibility. Okay? Does this surprise you? Okay, I want to know how many this weekend are going to be drinking their beers? Who's going to be drinking their beers? I know, I've been with some of you. Okay? You're going to find a place. What, Thursday night special? I was your age too, remember? Okay, you can get what, a draft beer for what, $1? I know what you can do. Some of you may say, I'm going to cook. I'm going to cook. I'm going to eat. I don't care. Why? Well, we all have different coping methods. Okay? That's all I'm going to say. We all have different coping methods. You know, we all need a break. Okay? Please, if you're doing anything illegal, do not go out in public. Okay? Please keep your cocaine or your marijuana in the house that you may be growing in your backyard. You may be ordering those brownies, right? Doing this little long break to stay in your house. Okay? So, I've been doing this too long. Okay? Too long. Okay? This is something that we may not think about. But again, when a human being cannot find coping methods, one, what can you do? Assess, advocate for them, get them a psych consult. Oftentimes, getting someone in there, because we all know who's going to be a psych nurse in here. I always have maybe one, okay. Usually one or two at the most in a class. So, but the majority, we're going to be like, you need a psych consult because, you know what, that therapeutic communication, I ain't very good at it. Okay? I did enough to pass the state boards and that was it. But a psychiatrist or a psychologist can often help that patient find ways to cope. Okay? And that is very, very important when a patient is suicidal. Okay? Because there's no coping going on. Okay? So really rational thinking, there's not any. There's no rational thinking. their whole world is now in a crisis situation. Okay? A lot of our patients lack support systems. Okay? That may be very hard for a lot of you to understand. But when you've been in nursing, you've been a nurse for a while, then you see that lack of support that a lot of our patients, they just don't have. And it doesn't surprise me that their coping methods are now non-existent, because support is very important for each and every individual, you know. And a lot of you may be sitting there saying, and I often do this too, and it's hard not to say as a nurse, how can you commit suicide? How can you take your own life? To a lot of you, that violates your beliefs in life, in your religion. It's like wrong. To some of you, it's like abortion. You don't believe in it. How do you take care of someone non-judgmentally? Makes you think, doesn't it? And it's going to take you a while. It will take you a while, guys, I promise you, to walk out that hospital door or wherever you work and let it go. Just let it go. When you walk out of that hospital and you say, I did the best I could as a nurse. I cared for them. I advocated for them. I did everything I could, then you got to let it go. Because initially your thoughts will linger on that patient. Because it doesn't correlate with your beliefs. And that's something I want each and every one of you to think about, okay? As you continue in nursing, you've got to stay non-judgmental. You are a professional, and it may violate your beliefs, okay? Taking care of many patients, you know, especially pregnant women that are abusing drugs. They come into the hospital seeking drugs, and they're pregnant. I have a hard time with that. But it's not me to make a judgment call on that person. So if they have taken or tried to take their life, I may not believe that. I may not believe that's right. But it doesn't matter what I believe. All I can do is try to take care of it. Has any student in this room known somebody that's committed suicide? Oh my God. So again, your feelings can take over, but I will tell you as a nurse, you have to stay focused, you have to stay non-judgmental, and you have to remember you're a professional, and you will take care of anybody that comes in your path. So, I encourage you to look at your own beliefs, because a lot of things we encounter in nursing are very, very difficult. Okay? And that's how it is. That's just the way it is. This organized plan, extremely critical. When you start talking to a patient that actually has a plan in place, that means they've been pondering this. They've been thinking about it. Okay? So this is the state they're in, and this becomes their focus, the plan. Okay? Now, like I said, there's a lot of patients out there that have suicidal ideation. But they may or may not have developed the plan. Okay? So that's very, very serious when your patient is in this state. Because again, their minds have been thinking about, how do I do this? Okay? Another risk factor, again, goes back to support. But again, looking at basically immediate family. There are a lot of patients that we encounter, as many of you already know, that have no one. Don't you ever notice like that patient doesn't get visitors? And you ask the nurse, does anybody ever come see that patient? No. How does that patient feel? Now they're lying in a hospital bed. You know their coping methods have been very, very challenged. And they have no one. No one that comes to visit. So when you see that, you often say to yourself, you know, I mean, for me, I could understand why you feel hopeless, worthless. Nobody cares about you. That's like a lot of our veterans that we saw in the psych area. They felt worthless. They felt hopeless. That nobody cared. And they weren't the same. They weren't the same when they came back from combat or war or whatever. So it's very, very difficult. Chronic sickness. Now this one is one you will see. And I know a lot of you think, okay, suicide, you know, da-da-da. Especially younger clients who will abuse their bodies knowing they have a chronic disease. Okay? For example, a patient who knows they have a kidney problem and they're diabetic, type 1, and they constantly abuse their body. And you see them over and over and over again. And I know a lot of you have heard that term, repeaters, frequent flyer, train wreck, right? That is often a sign that you need to be aware of. Because if they continue to do that, it could lead them into the crisis state. Okay, and I know a lot of you see that. You see the frequent flyers out there. Okay, and that is unfortunate. And it's very hard as a nurse. You're taking care of, I've been in the unit many, many years, and taking care of a 16-year-old who won't take their insulin, who doesn't eat the right foods. And you keep trying to teach them, you're going to lose your eyes, you're going to lose your limbs, you're going to lose your kidneys. I don't care. I don't care. I got to live. I don't care. And they come back over and over and over again. It's like a smoker with emphysema who says, I'm not stopping. I don't want to stop. So these are some of the critical assessment tools that can help you to not take this person for granted, or persons. Okay? You do not have to be in a psychiatric unit. Many of you in the emergency department will deal with this. Many of you, I know Kayla's had to deal with it, and a lot of you on the floors will deal with it. A lot of you in your own lives have already, as the hands went up, know somebody that has committed suicide. It is very, very hard, okay? But as a nurse, I want you to remember, you're a professional. You may not agree with this type of death, but you must take care of that patient non-judgmentally, because that's what we do. nurses. Okay? I'm going to go over this, and then we're going to take a break. This is such a morbid topic that we're going to need to liven it up. So, as a nurse, you identify risk factors. You are very concerned. You have gotten the site consult, and guys, I'm going to tell you, safety is now the priority. What have I tried to teach you? Priority takes a question to a different level. You must remember that. It becomes safety, Maslow, physiologic. Therapeutic communication goes out the door. Okay? Priority is a different animal. Do you plan to kill yourself? Is an example of what to ask. Do you have a plan? You know, a lot of people will leave what? Notes. They'll write it. They have a plan. And above all, do you have the means to carry out this plan? Do you have access to firearms? Do you have access to lethal tools? Do you have that access? So these become critical, and you can see this is yes or no. Yes. Yes or no. Yes or no. Therapeutic communication went out the door. You are concerned for their safety at this point. Okay? So I'm also trying to help you with testing as well. Okay? I'm going to go ahead and break since it's such a morbid topic. Go ahead and get caffeine. I know there are people that... This is unfortunately a problem in this country. Is bullying. For those of you who have children, you may already be aware of that. They have very strict rules, but it still occurs. And, you know, technology, as many of you know, is a wonderful tool. But students, I mean, not just students, but children, adults, can even get involved in situations with, you know, relationships on the computer. And it's very, very unfortunate. And I guess my question to you as nurses, how can we help stop this problem? As you can see, what happens is these kids end up feeling just like we just previously talked about. Failures, worthless, hopeless, depressed, and then eventually their coping methods, which we've already said in children that are 15 or younger, during that time can be very, very difficult. So what can we do, guys? Did you bully? Were you a bully? Were you bullied? I mean, I may be talking to some of you, right? And you have to think about how that other person feels. And kids don't. I mean, kids can be very, very cruel. Some adults can be very, very cruel. And why did I bring this out? Because it is such a huge problem. You know, these kids don't report this. They're afraid. And I guess, you know, raising my own children, I get it. You know, they don't want somebody to know they're being bullied, right? But just as you saw, this alone can lead to suicide. And it's very, very unfortunate. So as nurses, you are not just nurses in the hospital. You will be nurses in your church, in your community, in your home. Okay? You're the one, your neighbor will tell you everything you did not want to know about them because you're a nurse, and you're a nurse in the school. And it may not be your child, but you have a responsibility to try and advocate that bullying is wrong, just as it's wrong in the work environment. Those are called in the literature hostile environments. Okay? A physician has no right to treat you in an inappropriate manner, I'll say, and that means bullying. You think it doesn't happen? It does. Okay? So, you need to think about that. They have no right to treat you like you're worthless, you're inferior. They don't have that right. And what do a lot of us do? Miss Hyde will tell you, I will tell you, you learn to develop some really thick skin. And you're a professional, and I encourage you to walk away. And use your chain of command. Is something going to be done about it? I can't say that. But you do not have a right to be treated with hostility. Okay? You walk away. And you report following your chain of command. Okay? Because it can happen. Encourage your younger people to report such things. It's wrong. No one deserves that. And children, and I don't think a lot of adults, I've already said this topic is very sensitive. A lot of people just don't get it. Right? But as nurses, you're non-judgmental. You go in there and you're there to take care of somebody, regardless of your thoughts and your beliefs. Okay? So, it's wrong. Regardless if you're an adolescent or an adult. Okay? And I'm just going to let you know. You know, I've had physicians yell at me. And, yeah, when I was a new nurse, I would go in the bathroom and cry and da-da-da. Well, you know what? It got to a point, I don't deserve to be treated like that. Okay? If I yell at you, you should walk away. If you yell at me, I'm going to walk away. Because you don't deserve that hostility. Okay? You know, granted, oftentimes we need to, you know what we always say, go cool down. Go over there and cool down. Okay? Get your thoughts, get your coping abilities back in some sense of order, and be a rational thinker. Okay? Now, the only time that I will tolerate a physician raising their voice at me is in a critical, usually like a code situation. Because you know what? I'm probably yelling too. Because somebody's life is at stake. And I don't, you know, all you care about is trying to save this person if they're a full code. But other than that, no. You're going to develop some thick skin. You remember that when you're a nurse. You do not deserve hostile treatment. Not from your patients, but definitely not from your physicians. Because it will happen. She agrees. It will happen.
In fact, there was a case that in Raleigh when I was in Durham, a physician in the OR basically threw a scrub nurse up against the wall Basically, he was charged with assault battery. Lost his privileges for that hospital and every hospital in the area. Had to move out of state because the medical board censored his license.
And that's pretty extreme, but I think Ms. Hyde will agree with me that, a verbal is, there are physicians that'll yell. I mean, they're very inappropriate. And like I said, you say, you're not talking to me like that. You learn to get some thick skin. You don't let them make you cry, or make you feel inferior, or you're a bad nurse. No. And it's interesting because when you look at the statistics, guys, we have a lot of people in high business areas and in healthcare that have high suicide rates. Why do you think that is? Stress. Right, stressors. Remember, that goes back to our previous discussion about stressors and not. As nurses, I want we've already looked at safety. In particular, I want you to not take behaviors for granted. Abrupt changes in behavior. Think about it. How long does it take those wonderful antidepressants to work?
3 to 4 weeks.
3 or 4 weeks. So, you have a patient depressed. Right? They're on antidepressants. And then you see their mood change. They're happy. They're talking. They're doing things they didn't do before. As a nurse, please don't say, "Oh, you're feeling better and your meds have kicked in." This person could have finalized their plan. And they're relieved. They're very relieved. This was Robin Williams. He was relieved. Okay? And they're going to, they have the means to take their life. And they're going to carry out that plan. Okay? So, be very careful of abrupt changes in behavior. Be very careful if a patient starts giving things away. Here, you're such a wonderful nurse. Let me give you this. Okay, don't take things like that for granted, guys. I'm not saying that everybody's suicidal, but you need to be alert. You need to be alert. Okay, giving stuff away. Asking questions such as, when do the CNAs come in and check on us and clean the room and... I mean, it's like, what? Very focused on the medications. Where are those meds? That's not going to happen so much probably in the hospital because there are such resources that keep things locked up, but at home? Where are those meds? Where'd you put those meds? You need to be thinking about that. Again, most of you should already know this, but I know some of you, I've had my students, man, they love their guns. Okay, some of you may hunt, that's fine, but guns should be in a place where people can't get to them, right? And now I'm not just talking about children. I'm talking about other people who do not have any need to be near those guns. And like I said, you may not have thought about that before, but you need to think about it. Okay? Because these types of things give them the means to carry out that plan. Okay? So, when your patient has been identified, okay, you need to take action. You stay with them. You have got to not ever leave them, and they need a one-on-one observation continuously. And I mean even to go to that little bathroom. Because a lot of you have noticed these doors, you take a bed sheet, you tie it to that little door, you could strangle yourself quite easily. Okay? Not that we're going to try and see, how long it would take us to hang there, but we could do that. So, you need to look at that environment. You get everything out of that environment that is a potential way for them to commit suicide. Okay? Do not leave soda cans in there. You break off that little baby, they could slice their wrist in a minute. You don't leave utensils in there. And in the hospital, they have policies about a patient being on suicide precautions, okay? You have also got to make sure they have adequate food and nutrition. So, how many of you, I want to know, have sat with a suicide patient? I know you don't like it. Oh my. And what do you do when they say, I got to go to the bathroom?
Can't close the door.
I can't pee with you standing there.
Sorry, Charlie.
Sorry. Sorry.
I'll get you some water, Ronnie.
Sorry. Oh, gee, my bandage is coming off. Can you go get me something?
Sure, just as soon as you're finished.
They will do anything, a lot of them, to try and manipulate you to go out of that room. Okay? Don't do it. Okay? Because that is when they can carry out their plan. Alright? So, I want you to be very, very aware of some of these. And at this time, I will go over the wonderful PowerPoint. And we'll look at that. Yes.
Do you guys know why whenever you push the bed buttons to lower the bed to the ground, they stop when you take your finger off of them now? They go wrong beds? There was a patient that committed suicide by placing their head under the bed and pushed the button, and they automatically go down. Okay, in the past. And basically he crushed his head. That's why Hillsong beds or any hospital beds now, to lower the bed fully to the ground, you have to keep your finger on that button. And then there are sensors that will not let you lower it if something is under it.
Well, and those are things you see. I would never have think of somebody trying to die that way. But a lot of you are not going to be in these, nice hospitals. Some of you may be in Podunk City, where our bed just goes straight to the ground here. So those are things you have to think about. I would never have thought. I have seen them try to get their head almost like stuck as a vice in the side rail, but not that. And that, awful. Easier. I can think of much easier ways. Less painful, yeah. But again, that rational thinking is not covered. There's more statistics. As you can see, depressive disorders, huge problem, right? I covered the most common signs and symptoms that you see with adjustment disorders. So, again, something that as nurses we will encounter, okay? These are some of the updated stats. You can see fourth leading cause of death here, and even our older population. So a lot of that goes back to what we discussed in the first hour. I think I went over this. Some of your cultural information, that again, this is the most up-to-date information. Okay? And it's very important, like I said, as nurses, that we identify risk factors, assess, and intervene, whether that be advocate for a psych consult or place them on one-to-one observation and suicide precautions. So that's our primary role. Here are some more that lend back to that mnemonic that I gave you, sad persons. I just think that's more of a concrete way to remember your risk factors, okay? You please do not memorize those numbers. You know, I'm just letting you know that it is a scale. As a nurse, I want you to be able to identify who's at risk and assess. This goes back to our lack of support, no spouse, no children. Obviously, that's a given. Financial status is definitely going to affect coping. I often hear my nursing students, I'm broke, I'm broke, I'm broke. That's a stressor. I know that's a stressor. You know, that's for really anybody. But at least for you guys, this nursing school will end, and you can become a nurse and get on that almighty payroll. This one we did discuss. This surprised me, but I guess a lot of you have. Who in here knows a lot about guns? You do? Okay. Do the majority of homes in America have guns? Yes. They do. How easy is it? This is another question, because I know this came up in the government about access to guns, especially when we've had these mass killings. How easy is it to obtain a gun? Okay, so what's the problem here? Why is it so easy to obtain a gun? Constitutional rights. I mean, you know, you would think after some of these mass killings, I mean, you think about other countries, I mean, if you did something like that, they'd chop your dang head off, you know. But in America, is it because of constitutional rights? So I could go in a store, what you're telling me, get a license and buy a gun.
Yes.
You have to go to the sheriff's department.
You go to the sheriff's department.
You can't have a felony.
Yeah, you can't have a felony.
Oh, I can't have a felony.
No, you have to do a background check.
Yeah, background.
And they do a background check at the sheriff's office.
Self history, and if you've been committed,
They don't do that all the time.
Yeah, you've been committed one time.
if you've been involuntarily committed, you can't get one.
You could also get a legal gun. Well, yeah, they're easier.
So how many people go to the sheriff's department and get...
Not the criminals.
That's the legal one.
So there are people out there, hold on, I'm just trying to get it straight, guys. So there are people out there that will sell a gun without following the proper channels.
Yeah. Yeah.
Well, you can sell a gun person to person without a background check or anything.
Yeah.
So I can sell any gun I have to anybody in here.
They can have bodies on it.
But in North Carolina law, you have to have a purchase permit that you have to retain.
Not for me, it has to be a dealer. It has to be a dealer.
If it's person to person, they still
So
have
they just,
That's just like I heard on the radio, they're telling us to be responsible to or y'all gonna have fighting going up here.
very interesting. So now I understand, stay with me. Now I can have a better understanding why this is. Because I could say, Joey, I'm in trouble. Can you sell me a gun? No, which is so amazing.
Maybe it's a little more effective than anything else.
Amazing. You know, I've never bought a gun. Okay? Never bought a gun.
knives.
It ain't really like guns, because when I was in school,
I should buy a gun.
guns are crazy as hell.
Can easily see that. Others of you may not. You may be atheist. I don't care what you are, but that some of you are very devout about your faith. That is fine. Again, family history. Kind of scary. You know, it makes you kind of go back to think about, do I have something genetic? You know, that's going to make me do something. But family history is higher risk. I guess that would be definitely other reasons, obviously, than just genetics, maybe environment. We've gone over this, again, trying to give you something a little bit harder, a little bit more finite as far as those risks, okay? And you can see, you know, the different points, basically what the scale says, which is solely a scale to give your psychologists, psychiatrists, nurse practitioners, whoever, a little bit better idea if this patient is requiring psychiatric help. Above 8 is this I just talked about. Obviously behaviors that I hope from now on you pay a little bit more attention to if you did not before, that can indicate that this person may be thinking about suicide, okay? This is essentially why I was trying to bring out about the cyberbullying, okay? And what people can feel simply by someone's other words. Again, this goes back to behaviors, dramatic mood, focused talking about it. The world would be better off without me. My family would be able to go on easier without me. So take note of that. What I tried to do is give you, again, just a little bit more as far as if you do assess and think that somebody is suicidal. These are just a little bit more. Some other questions. Again, what did I say? Priority, safety. Okay? Therapeutic communication, out the door. You need these answers from this person. Again, looking at, do they have the means? This is a critical risk factor. This I just went over, okay? And again, I know you guys right now, you do a lot of sitting with them, but as a nurse, you will have to provide holistic care, meaning that they have to have adequate nutrition and hydration. This is probably going to be more so with maybe patients with suicidal ideation. Again, this is part of helping them identify coping. mechanisms instead of taking their life. Just to let you know, your physicians can, this is a legal document, it goes to the court. Essentially, it's referred to as the Baker Act. This is why you see some of your patients being held for 72 hours, okay? And that can be voluntarily or involuntarily, and then the healthcare team will evaluate if they need further care and hospitalization. So you can involuntarily or voluntarily commit somebody for 72 hours. I was looking up yesterday, I was telling Ms. Hyde, I said I really kind of wanted to know what is the anticipated length of stay in the hospital. It's less than a week, 3 to 5 days for a diagnosis of suicide. Not a lot of time, is it? I did bring out about your older adults. Showed you the video about the younger patients that we may encounter, and I think I've pretty much covered that. I'm going backwards, as always. This is some I got from Ms. Hyde, just adding to some of the other diagnoses that you may see. This one, risk for suicide, risk for, the current is risk for self-harm or other directed harm. Again, I've given you some of your goals that you should be thinking about. This goes back to what I have tried to emphasize to you about non-judgment. You have a responsibility as a nurse to be caring, showing compassion, rapport, but always keeping your priorities in order. Okay? These are, again, from your book in the literature. It talks about establishing a contract. Obviously, if you're in the hospital, that's going to be probably your psychiatrist, your psychologist doing that. Establishing a contract that the patient will not hurt themselves while under your care. I hate this thing. Say that, don't I, every time I get up. Very, very important, again, with a 3 to 5 day length of stay. Very, very important to educate your family. Okay, especially why? What do you now know? That previous attempt at suicide puts you at very, very high risk for another suicide attempt. So families have to be educated about the risk factors, about what to look for, the behaviors, and the environment. Okay? I share with you some of my own stories about the impact suicide can have. This goes back to kind of my stories, guys. Again, I often, if there are certain situations that I have encountered with patients that, I'll be honest with you, I don't know what to say, so I just sit with them and tell them I'm there. And that's where your silence comes in as a therapeutic communication technique. Be very, very cognizant. Especially, you know, I always was a nurse who didn't mind working holidays. Not except when my children were small. But because I always told myself, you walk out of here. You walk out of here at the end of the shift. But you know, maybe it's Thanksgiving. They don't walk out of there. Christmas, they don't get to go home. That can have huge impact on a child and an adult. So you guys as nurses need to be very, very cognizant of that around those times that you know how it is. It's supposed to be the wonderful time of the year, right? Well, it may not be for a lot of our patients that we care for. Safety, safety, safety. Then therapeutic communication. Okay? Listed for you, as you guys did yesterday, resources. Very, very easy to remember. Okay? This is available 24/7. Okay? Websites. So if you can get that person to know there is help out there and it's confidential. Okay? So again, know your resources, especially you guys. There is no excuse. You're in a world of, if you don't know something, what do? Google it. Okay? So you have no excuse. You can get your patients to know that help is there. A very morbid topic, but one that is covered as nonsense. What we're going to do now